HIPcast is brought to you by Enterprise Social Record.
Today we have a special treat. We have a person that Seth and I can admire and learn from. She is probably considered a professional podcaster. And today we're going to talk about her health information journey. We're going to talk about her podcast called CodeCast. And then we're going to talk about some of the challenges that she faces or that her clients are facing in our health information world today. Terry, welcome.
Thank you for having me. I'm glad to be here.
It's so good to have you. Where is it that you're from?
I'm actually coming from Laguna Beach, California. So it's nice and sunny, and I can hear waves out my window if you really listen. So yeah,
it's wonderful.
Sorry, don't mean to brag, but yeah.
Don't mean to brag. Well, it doesn't hurt my feelings today because when we're recording this, it's actually the fall in Tennessee, and it's a glorious day. There's beautiful leaves, there's sunshine, there's blue skies. It's gorgeous. So I think we're both having a great day.
I can hear waves outside of my window, but it's just the cattle getting in the pond out there.
I love it.
So we don't typically read a bio. So the question is, and we'll get into, I guess typically our first question is, tell us about your HI journey, which is kind of your bio. So I almost say, well, let's just start there. Tell us how you got into HI, and then tell us who you are today.
Well, for those of you that, don't know who I am, Terry Fletcher, and I guess my title, I put myself out there as a healthcare coding, billing, and reimbursement consultant and auditor and educator, I guess, jack of all trades. But I started in the industry actually as an RN and, years and years and years and years ago. So let me get all those years in there. But you can't be a nurse and not like the sight of blood. So I was like, I'm moving on from this. But did that for a few years and then really liked the administrative end of medicine. And so started really looking at coding and billing. And that was way before what we have now, as that's called the CPT book. Back then it was all based on just time and you could do whatever you want. And, it was this thick, now we're, so, in the 80s, 90s, 2000s, and, here we are now. But it's evolved. I did a lot of education, going out on seminar tour. I used to travel 200 days a year, which did not bode well with my daughter.
Wow.
But luckily you have good support system at home. My husband's a rock star. But yeah, just, kind of evolved that way. And then, as your kids get older and everything, you switch gears a little bit from traveling to things you can do locally. And then COVID hit, and I actually 2 years before that, I'm like, you know what, my daughter's in high school. I'm going to basically just do, things as much as I can where I'm not traveling. And then that hit. And I was like, well, I knew something maybe nobody else did. I don't know what's going on there. And now I'm about 90% virtual, just between audits and education and everything. And it's great to be able to not have to be on the road all the time. But I do a lot of auditing on the coding, billing, and documentation and compliance side for physicians and for payers. So I do both payers and physicians. So it gives me a unique perspective of what's out there and what they're looking for, and just keeping them out of trouble.
Well,
yeah, it's a different world that I live in. I avoid the coding conversations as much as I can. I'll just lean on Shannon through the whole thing, because that was part of HIM school that, outside of my papers looking like they'd been murdered because of all the red pen from Beth Bowman, one of the instructors, but my coding class was probably my weakest class in that.
Well, when Shannon first introduced me, she said, we have a person. I was like, oh, she's going to say a person of interest. It was like, wait. I was like, well, I finished the sentence.
Yeah.
I love that you said the 80s and 90s, and that you said, the CPT code used to be like this and now it's like this, and the ICD-10 used to be like this and now it's like this. Yeah. And it's so crazy. But if you were in the 80s and 90s, were you coding? Because I think you said something that I believe the answer to my question is going to be yes. You said you just coded and it just went and they paid you what they paid you. Were you a pre-DRG coder?
Well, I never did hospital facility. So
Okay.
that's where the
Okay.
DRGs are and things like that. It's all been professional side, so physician billing. But what's funny is that I was actually having a conversation on a podcast that I recorded earlier today with somebody. And I'm from the time where we typed our claim forms, where we
Ah,
used a pegboard system, which for those of you that don't know this that are watching this podcast, it was a patient ledger, and then you had to press down with the pen over a pegboard to read what yeah, it was bad. And so it was bad, but it was the days of no computers. I mean, God, I'm aging myself. Yes, I'm 150 years old and I made it this far. But it reminds me of when because my daughter's now 30. She's a high school teacher, but I remember when she was in college, she's like, "Hey, we're going to the Business Machines Museum," and she took a photo of a IBM Selectric typewriter, and she goes, "Have you seen this before?" And I immediately hung up on her. I'm like, "Go away." So, because I'm like, yes, that's what we used to type our claims on. So things have really evolved. So I am amused a little bit when I hear people complaining that their computer isn't, working well, or, the internet's out or whatever. I'm like, cry me a river. Like, it'll be up soon. I've seen it all.
That is fun to think about those technologies from back then.
Oh,
My
it's
first job in
crazy.
a hospital was in an ER, and we still had the embosser cards in the registration area.
Yeah.
So we would have to produce the embosser cards and then go through and stamp all the pages that were in there.
yep.
And it's like,
Well, remember fax machines that had the rolling,
oh,
weird
the
Yeah.
paper
thermal
that was
paper.
you'd come in the morning, and on the floor you'd have all these faxes, and
Yes.
yeah. Well, my daughter's students are getting back at her now because they're like, "What's a CD?" And she goes, "Oh no." She goes, "Mama, guess what they asked me?" And I just laugh. I'm like, "Uh-huh." And tell them you knew what VHS was too, the
Oh,
tape. So it's just funny where we are with technology today, which I'm a little nervous about AI because the safeguards, the guardrails are not really there. And I don't know if you guys just read in the news. I don't think it's not really healthcare related, but it could be, because the OIG is so involved in everything that happens from a medical perspective. I guess somebody at the DOJ was using ChatGPT and AI to write um, orders and certain documents, and they did them incorrectly because it doesn't have reasoning or nuance. So it's what you input and what comes out, and it was bad. It was
yeah.
just bad. So in healthcare, we're dealing with hallucinations. So you put in something like ruptured, and it automatically wants to go to Achilles, and it could be appendix or something.
Uh-huh.
So
Oh, interesting. Are you seeing
yeah.
that quite a bit? I guess two-part question again. We talked about this before we went live here. That we'll chase rabbit trails. That's what we'll do. But you
I know.
sparked some really fun things here. In the provider space, are you seeing providers utilize AI for documentation that doesn't necessarily line up with what's going on in the visit? And then on the other side, from the payer perspective, are they using AI to do denials or audits or whatnot? And what are the issues that you see on both sides of the fence?
Well, to the answer to the question is yes on both sides. And it's unfortunate because AI does have a place in this. It just, again, it needs to be perfected, in my opinion, before it was rolled
Mhm.
out. And it's not yet. And so that's the problem, is that it's learning as it's going, and it's at our expense. And so, I'll go on an on-site, consult at a provider's office, and I'll be sitting in the waiting room waiting for somebody to come out and greet me. And I can hear a provider using like the Amazon, Alexis or whatever, and they'll be screaming and question, "What do I do for this?" And I'm like, "You've got to be kidding." And everyone in the waiting room's like, "What's he saying?" I'm like, "Okay,
Yeah.
HIPAA. Anybody know that acronym?" And then, and then I hear the response, and having a clinical background, I'm like, "That's not right. You don't use Augment for that," or something like that. But
Hmm.
the payer side, when they're using the claims denial and they're using the AI for that, they're getting a lot correct, but they're also getting a lot that is algorithm generated, which, that's not appropriate when you've got all kinds of different policies and nuances and updated, diagnoses that link to something. So it tends to miss things. And I think that on the clinician side, it misses things too.
Yeah, it misses a lot. I do see I do see vendors digging more into all of the sources now. They're getting better at including like LCDs and NCDs and even payer specific medical policy. So they are getting better at that, but not all vendors are doing that, right? Not all vendors are pulling those things in. And this is part of forecasting what you should be paid. Some of this is related to price transparency. Some of it is kind of helping you pre-scrub, before it goes into the scrubber, so doesn't get rejected on your 837. So I do see, and I'll tell you, I believe it's because these companies have recognized we can't do this without context. And so I need somebody that understands the context, which means they've brought in health information professionals to their organizations to help them understand the data. What's missing here, right? What things have I not considered?
And to your point, here's something that's interesting is, now with the Information Act, where patients can get what they want and they get it in a timely manner for their records, you don't want a patient reading a record that looks like a Harvard paper with all of the, cited references and cited works, which actually are not always accurate.
No.
And those kinds of things.
Check all those.
Yeah. And so I do a lot of, audits, and unfortunately I have to do some manual because even some of the tools that have come out AI, they overcode or they undercode. I'm like, that's not right. And so we have to go back to kind of basics. And then it just reads like it's a cut and paste again. Remember, we tried to get out of that. And that's back with AI, and it's unfortunate.
I think it never left. I think we've been copying forward since 2011, right?
But what's the problem with that, is that you got the telehealth mix there. So I see this copy forward where they said I palpated a mass in the right groin. Yeah. I'm like, really? How'd you do that?
Virtually.
Yeah. How'd you do that over the phone, or how'd you do that over the video? Or what did I see recently? The it was a breast exam, and they went into detail how this looked, felt, and everything.
Oh,
and I'm
goodness.
like, no, you didn't. And I looked back at when the patient was in person, and they just pulled it forward. And I went to the provider and said, look, this negates the record. You didn't do this. And their response was, well, I don't use the history and exam to level a code. I'm like, oh, gosh. Well, you use it for medical necessity, and it's not here. So, you can't pretend you did something when you didn't.
Oh, my goodness. Oh, my goodness. That is so crazy. So tell our listeners, what is it that you talk about on CodeCast? Why did you start it? How's it going? What kind of trouble what kind of good trouble do you get into on there?
Well, and you may not want to ask me that question. So, one thing it's hard for me to do is keep my politics out of it. And so that's been a problem. I'm a conservative. Let's just leave it at that. And so I went like my CodeCast this week. I was ranting about the shutdown. Oh my gosh, was I ranting? And I listened to myself after I published, like, oh, that's not going to go well. And actually, I ended up getting a lot of direct messages. People like, oh, thanks for saying that. Nobody's saying that, And I was top of my game. I could tell I had about 3 cups of coffee there. But I was having a nervous breakdown about the whole shutdown and how who was affecting, and everyone just play nice in the sandbox, get your, stuff together. But I started in 2017, and I was, telling Seth prior to this that it was really just to, because I was on the seminar circuit, and out there, every week teaching seminars and teaching webinars and conferences and all that. I really wanted to have a way to just give information that I kept getting from questions and, follow-up thing. And I have a membership where people can, pay to ask questions through email or whatever. I've had people in there for 20, 30 years. It's funny. But it just seemed like it was good to have a conversation of the hot topics in healthcare. And we have 2 or 3 million downloads at this point, and it's been quite the journey. I mean, I get so much business from the CodeCast, and we have all kinds of sponsors. And again, on Seth, we've got like mainstream sponsors, Netflix and things like that. I mean, we do have some healthcare sponsors too, Decision Health, things like that. But it was just funny when I get a call, I'm thinking it's a crank call. I'm like, that's not who you are. And they're like, no, really. And they have to convince me that they're actually calling from that company. I'm like, oh, okay.
Oh my goodness.
So, but yeah, we like that. But I do it just because, and that's a solo podcast. It's just, I guess, to hear myself talk about what I want to talk about with nobody telling me I can't.
What's the frequency that you post on CodeCast? Weekly,
Um,
bi-weekly?
Well, I have a copyrighted hashtag Terry Tuesday. So it's every Tuesday. The NSCHBC podcast that I'm a host of, I've been doing for 5 years for that company, is the second Tuesday of every month. So Tuesdays are usually my deal, because you can say Terry Tuesday, and that's how you can find it.
That's pretty clever, and we'll try to link in our show description below for folks to be able to find you as well, and
Thank you.
and try to tag you. That it's all about cross pollination. I didn't know about you until our previous guest Stephanie had mentioned, and I was like, wow, this is kind of cool. And then when we started talking about how long you've been doing it, Shannon and I are newbies and still trying to figure out how to get our accents out of the microphones.
Yeah, you kidding me?
I'm not trying to get my accent out. No, he might be, but I am not.
Yeah, I like your accents. They're cool. I have a really big client from Mississippi, and I love talking to them.
Well, they
Their
have a
accents
great
are
accent in
awesome.
Mississippi.
Oh, yeah.
Yes,
great.
I
It's
love
awesome.
it.
But no, a lot of the episodes that I do on the CodeCast, I try to focus on coding, and it always seems to be coding, billing, and some kind of compliance discussion, or what's going on with healthcare, where there's always a crisis. And so, trying to just walk people through that, talking about the telehealth realities, because people don't know the realities. And, this is, then sometimes I'll be like, okay, I'm going to do a series on modifiers, or I'm going to do, the next 3 are going to be on cardiology or gastro or whatever my specialties are.
Mm-hmm.
Yeah, so
sounds like a never-ending opportunity
I've never
for
repeated
discussion.
one. And I have 420 episodes. So,
and like you say, the book went from here to here, and the content just keeps changing.
Right.
Yeah, I can imagine what it sounded like when we were moving from ICD-9 to ICD-10-CM and PCS. I bet you had some really interesting conversations about. Well, you may not have, being from physician billing side. Did you ever do
ICD-10-CM? Yeah, I'm the CM, the clinical modification.
It was a lot. There was a lot of change. I think we went from 17,000 codes to over 90,000 codes just from 2014 to 2015 when we went to ICD-10. Is that right? Maybe it was 70-something thousand at first, and now it's over 90,000.
Yeah, and I think from the professional side, we went from, I think it was 80 to 160,000. So many. Yeah, it's crazy. And the things that they have coding for, sometimes I'll do just like a quick 15 minutes if that week was just busy, soliloquy on ICD-10, funny stuff, like falling off a commode. It was funny to me, maybe not to the person who fell off, but things that relate to, a holiday, overeating turkey, or there was one that was, what was it? Getting hit by an alien vessel. And I'm like, seriously?
Yeah, struck by a duck.
I know.
Bumped by a dolphin.
Right. Exactly. And I mean, there's things on and then you have to have a secondary diagnosis to say how you did it. And people actually would DM me and go, but they don't want us to tell them how they did. I'm like, I bet they don't. Yeah.
That fall off the toilet was fecal syncope, right? Nobody wants to tell you that.
Yeah. They don't want you to say how it really happened. So
for the students out there, you should know coding is fun, because now you can code all of these crazy things that
it's amazing.
I assume it's like the warning labels on things where they say you're not supposed to eat this floor cleaner or whatever. I assume the codes are there because it's happened to somebody.
That's exactly right.
It really is. Well, and I think one of the diagnoses that I find to be not amusing but just silly is the one that says a diagnosis in somebody who has a complaint which actually wasn't accurate or it didn't really happen.
Yeah,
I'm like,
that's real though.
yeah,
I mean, I remember working in a hospital, and at the holidays, we would have folks that would come because they didn't have family, and they would come through the ER and they would always say chest pain because that gets you in, I'm talking 20 years ago, that gets you in the door. And then you're going to be at least one night in observation, maybe two as an inpatient, potentially 20 years ago, remember. So you could stay 2 days and still be an inpatient, but they would be there, and their chief complaint was chest pain. But then after study, there was nothing, and there was always documentation that said person is lonely at the holidays,
yeah.
and
And now there's actually
why there's a
diagnosis for
code.
that. Yeah, there's
Really?
actually a secondary diagnosis for problems with, what is it? Problems with in-laws at the holiday table. And I was like, oh, I need that one in my
That's a
pocket.
secondary code.
That's a secondary code. I was like, okay.
I
Yeah.
didn't know there was one that had at the holiday table, but even in the SDOH codes, there's a whole slew of problems with step parent, problems
Yep.
with foster parents, problem with parent, there's a sibling rivalry code. I think I'm going to get my brother and sister a t-shirt with that code. They're not even going to know what it means because they're not in healthcare, but it's going to be like, love y'all. Happy birthday.
Yeah, exactly. I'm waiting for them to have one about a child who doesn't know when to say, mom's credit card is not for you anymore. Yeah, no matter how old you are. Yeah.
Yeah,
Sorry,
complete
Summer, if you're
meltdown.
listening to this. Yeah, exactly.
That's
I'm
fantastic.
like, you're out of the house now. Move on.
So what are the biggest challenges that you see in the provider space, in the practices and whatnot, that folks are dealing with today outside of in-laws? And what do you say the current state of the industry is?
Well, actually, it's two things, and I think this is something that Shannon may find that she sees this as well. So prior authorizations, that is actually, you probably saw the alphabet soup after my name. I actually got a credential in that because I really thought it was so important to the revenue cycle management. Yes, I'm a coder first and an auditor, biller, whatever, and compliance person, but prior authorization is crazy right now. And as much as, they've attempted to fix it, I think finally we have a HHS secretary that's putting a lot of pressure to fix it. The problem is, and there's a portal you can send something directly to Secretary Kennedy. When he said we are asking for them to volunteer and to be on their honor, I'm like, no. You need to say this is mandated. You need to do this and stop making prior authorizations so ridiculous. That's one thing. And patients, have to wait. But the other thing is coordination of benefits. So when the patient's got dual insurance, or, they think they have 100% coverage and they don't. They, not all the time. They've got, coverage for one, and then maybe the secondary says, well, you already got paid enough by that, payer, so we don't kick in at this point. Or, the practice doesn't know who's primary and the patient is confused, and, then you bill it out, you get paid double, and then everyone wants their money back. So there's a headache there just in the revenue area when it comes to that.
Yeah, and folks have to requalify for some of those secondary things annually, right? You have to, even for the Medicare shared savings, where the state of Tennessee would pick up for covering your Medicare premiums, you have to requalify for that every year. And if you fail to turn in your documentation, now you're going to start seeing a reduction in your Social Security, or you did qualify for a Medicaid plan, and now you, for whatever reason, either you didn't send in your documentation or new requirements, you don't meet those, so now you're not going to have Medicaid as a secondary, and you think that you're going to be covered 100%. You find out that there's $1,000 plus deductible for a hospitalization, and you don't have Medicaid to cover it anymore, right? And that's always a surprise. So coordination of benefits, it's interesting because patients have no idea what that word means.
Right.
And, Seth, maybe that's another one of our patient advocacy topic opportunities is coordination of benefits, because patients don't know what that means. And then
but I know what that means.
even for us in healthcare, we might know what it means, but being able to get to the root cause of what's going on, it's not easy. And then we're separated from that person's kind kind of personal information in their account with Medicaid or with their secondary, and we can't even help them define who's primary and who's secondary. Some of the, I don't know if everyone uses it, but some payers use a birthday rule. Whoever's birthday is first in the year, that's who's primary. If
Right.
you've got two equal, I'm like,
Right.
well, who came up with that rule, and why
That's been
isn't
around actually forever, and it's mostly for kids now. So it's not for adults. It's mostly for kids. But
Yeah.
it's funny. I've set up a couple practices where a lot of practices like to do these community outreaches,
Mhm.
and I've seen colonoscopy Saturday where they do free screening. I saw. I'm like,
Sounds like a
okay.
great way to spend a
I know
Saturday.
there was a news article a year ago or so where these women did it for her, their 50th birthday and took a limo. I'm like, I'm out. And then, but I mean, good for you guys, good for you guys.
I'm a bigger fan of
But
Terry Tuesdays than I am
yeah, I know. I was
colonoscopy
like, I don't know about that. But they try to do different things clinically. And I said, you might want to have maybe a Saturday morning and, pay your staff a little extra and do a coordination of benefits and invite patients. Anybody who's having issues with your insurance or you need to explain to you. I had one practice. They said, Terry, we had 100 people show up and we had 2 staff members. I go, how'd it go? They're like, we had to order in. Like, and I bet you got some goodwill. They're like, now we're actually booked 6 months out because people are so happy we did it. So those kinds of things, I mean, administratively, people don't understand that healthcare isn't just clinical. People need to, you have to have, healthcare is about the entire package of what it is. And people want to know, what am I going to pay? What is the insurance going to pay? What am I going to be liable for? What am I going to be surprised with it? Now, you're not supposed to be surprised, but it still happens. And when you can address those needs, and also the patients won't say, I don't want to go to my doctor because I don't know what I'm going to pay. They're going to say, no, I'm fine because they explained it to me. So, just going back to your question, Seth, it's more about trying to, meet all the needs, not just the clinical side, but also the administrative side for the patient.
Yeah, I like when you say that the healthcare is not just clinical, because it is a business,
It's a
and there's a
business,
lot
yeah.
behind it that has to go on. And Shannon mentioned our patient education series. We kind of fell into that to where we're having folks on just to have a 30-minute conversation on, like, what's the difference between Medicare Advantage plan and traditional Medicare? How do you request information
You
from
asked
a
my
provider?
husband, he said, I can get a free gym membership or I can't. And I'm like,
yeah, exactly.
Okay, honey. Yeah. Okay. Yeah.
That
He
is
tells me all
definitely one
his
of the differences.
But that's not all of it.
That's all his perks. Yeah. He's like, look, I get, I don't know how they figure out this calculation, but he's like, I get $17 a month at the pharmacy online. I can buy whatever I want that I need. I'm like, really? He goes, that's the Medicare Advantage credit. And then he can go to any gym he wants. They pay for that and all this stuff. Cause he's an otherwise healthy guy. And he's just like, it's great. And I'm just like, okay, well, if you ever have to go into a skilled nursing facility, just see how great that is going to be.
Trouble.
Yeah, like, yeah, you'd want to have either Medi or traditional Medicare. I go, because Medicare Advantage are going to be like, no, we don't want you there. We're for healthy people.
Yeah. You've been there 4 days after your hip replacement. Get out.
You're out. Exactly.
Go home. You've got this.
Which is funny, Shannon, because Medicare Advantage plans are being investigated for too many HCC's hierarchy codes, but they only want healthy patients, but they overcode the sick diagnoses too much.
They want their healthy patients from SNF. They want everybody else's HCC to show their case mix. That's terrible.
Exactly. It's crazy. It's crazy to me. And I can say this because I educate them.
Are there solutions out there for coordination of benefits for patients, or is it truly just up to the providers and whatnot to try to help out their patient base?
And that's basically it. It's, the biggest issues are in primary care offices, because they have so many visits and so many little things, labs and, things that they do on top of visits, preventative care. And I have one urgent care client that's like, oh my gosh. And so, one thing that we try to get them to do and explain to them is that don't just have the patient responsible. You also have to check eligibility and you have to check coverage, which are two different things. Mm-hmm. Eligibility just means, is it active today? And then coverage is, what will they pay for? Right. And I think people mix that up and,
absolutely
say, well, the patient says I have. I'm like, well, people try to identify with a lot of things now. So you need to know what reality is and what they actually have. So, make sure that you also do your due diligence.
Yeah, absolutely. And Seth, you can in your electronic health record, you can most of your carriers are listed, and there's an API that you can click and verify benefits, right? Not necessarily coverage, not eligibility for things, but like are they eligible for coverage, not what the coverage is. But you can't do that very well for the secondary coverage. So the coordination of benefits component of that doesn't really apply. Like I could say, is this person have, traditional Medicare and Medicaid? It's going to show me they have Medicare, but if I run that on Medicaid to see if they're eligible, it's not going to come back with a right answer to tell me yes, because it's going to say I'm not primary, right? So no, I am not your primary coverage. As far as I know, and Terry, you may see something different, but I have never seen an EMR that employs a secondary, like a call out to say, hey, do you cover this person secondarily?
Epic does. Yeah, Epic has something in there. Cerner doesn't, and NextGen doesn't, and a lot of the EMRs, you're correct, they don't. From a physician standpoint. Hospital, I wouldn't know. But yeah, it's really a lot of manual work. But I think too many people are expecting the patient to do the work, and even though they should know what their coverage is, the problem is they want to be seen, and so they're going to tell you what they want.
And in the same thought, I'm sitting there thinking about my mother going, how do I tell her how to go into an app on her phone and connect her insurance to make sure she can see her coverage? Blah blah. I'm like, there's no.
It's interesting about that though. How old's your mom, if you don't mind me asking?
Late 70s, mid 70s. Hopefully she's not listening.
Well, the reason I'm asking is that my late grandmother, she lived to be 101. And I remember taking her to bingo when she was like 93 or 94. And this woman would have, and she used, those pen, like you can dot them and they're
the dollars,
right. So she had like 7 or 8, maybe 10. Yeah, she was a serious bingo player. It was at her senior center. And I have like 2 things and I couldn't even keep up. I'm just like, what? And they were so fast, it was like being at an auction. But then I'm like, okay, Nan, so let me explain to you how your Medicare works. And she was like, I don't get it. I'm like, I'm not buying it. I'm like, I've seen you in action at the bingo table. So I actually set her up a bingo card and said, we're going to play bingo and you're going to see if you can find what I'm talking about. And she figured it out. So you just got to use methods. It was pretty funny. She goes, I think this is cruel, but I get it. I'm like, sorry, but I know what you get.
It makes a lot of sense. Yeah.
That's fun. That's a fun game to play. That's awesome. Well, Terry, thank you so much for joining us. We will try to link your podcast in the social media post when it goes out. And it's been super fun. I'm sure that Seth and I probably want to talk to you about a lot of other things that, our health information professionals don't really care to listen to. They like the health information talk. So we appreciate you. This has been really fun.
Okay. Thanks for having me.
Yep. Thanks again. And Shannon, until next time, my friend.
See you next time, buddy.